Welcome to Advancing Health. Coming up in today's episode, a conversation with Englewood Health about the rise in the use of opioids since the pandemic. We'll talk about what providers can do to decrease their use and what Englewood Health is doing right now by way of prevention. Your host is Rebecca Chicky, Senior Director of Behavioral Health Services with AHA. She's speaking with Lauren Savage, Director of Population Health, Englewood Hospital, and Dr. Vinnidhy Dave, Director of Palliative Medicine, Englewood Health Physician Network.
Dr. Dave and Lauren, thank you so much for being here with us today to talk about this incredible topic. The opioid crisis during COVID did nothing but escalate, unfortunately. And the more creative the suppliers of opiates and synthetics become, I think the more challenging your job, our role in helping individuals with opioid use disorder, the more challenging it becomes. So I'm delighted to, first of all, let the audience know Englewood was a Foster McGaw Prize finalist. They were acknowledged and presented with this award at AHA's Leadership Summit in 2024. The prize was for a much broader perspective. They have really done a lot of work around all of behavioral health and improving access. But today we want to focus in on opioid stewardship. And I'm going to break this down in a number of ways. My first question to you is that I'd like you to provide some statistics. What are the driving factors that really allowed you to say, this is a problem, this is a challenge, and we have to focus on it? So can you start there? Everyone knows what's going on in their community, but they don't know what's going on in yours.
Yeah, I mean, I could start and then Dr. Dave, feel free to add to the conversation. I think you said it best, Rebecca. This is a problem in everyone's community, and nobody is surprised by the concerns that we're seeing. We do use our community health needs assessment to better understand our community and their needs. In the 2016 and 2019 community health needs assessment, the need for behavioral health increased tremendously. And at that point, we knew we needed to do more. We also were seeing it within our own patient population, within our community. And there was also a very generous family that donated to the hospital. And so in 2018, we were also able to open the Gregory P. Shattuck Behavioral Care Center. And this center is dedicated to behavioral health and to substance use. The Shattuck family lost a family member to substance use, and they were clear that part of this center should be focused on our treating our patients in our community on substance use as well. And it was through the Shattuck Center that we were also able to form an opioid stewardship committee so that we were really able to get a group of dedicated providers, multidisciplinary team at our hospital to come together to talk about the epidemic, to learn, what's happening in our community amongst our patients and to begin to address it.
I would say from the physician side of things, my background is internal medicine and then I trained in palliative care. For years, we always, thought about surgeons as the ones that were giving opioids first to patients. But there's been data over the last few years showing that hospitalists and internists were actually the ones that were exposing patients to opioids first from the hospital side. So I think that's where my interest came in, was really how do we work on decreasing the use of opioids in the hospital? How do we decrease the amount of patients we're sending home with opioids? After I read this article in New England Journal of Medicine where it was showing that internists were probably the ones that were exposing patients to opioids first before surgeons, as surgeons have done a better job with the last few years.
So a couple of things. One, I heard in terms of key success factors, Lauren, that you said is one, you identified the need, you had the data, you replicated it, you shared it. You then found a generous philanthropist to be able to provide you with the funding and the backing that you needed. But then you also created a committee. So this was not being done in isolation. And that really leads me to my next question. One key part, if I understand your program correctly, one key component is around prevention. And it is in terms of what are some alternatives to opiates, as well as what are best practices around prescribing privileges.
This is where my kind of work has been with the team and the task force, is really creating what a lot of hospitals are now calling ALTO, or alternatives to opioids. In the emergency room, we started it, and then we started it on the floors in the hospital as well to provide it to our internists, hospitalists, surgeons for normal pain things that we commonly see. So In the emergency room, we've created a protocol for back pain, kidney stone pain, headaches, intractable abdominal pain that's not surgical. And there's an order set in our Epic system where we put in non-opioids that can be given for those types of pains. So you would just type in alto, and in that, let's say back pain comes up, and then under back pain, there's options of steroids, muscle relaxants, anti-inflammatories, reminding providers that have been trained for years just to go to opioids automatically when someone's in severe pain, that these are all the other options we have. And sometimes, as physicians, sometimes when you're in the ER, you're seeing 40 patients. It's hard to remember. But now, when you type in pain and your alto pops up, and now you look at it and you see back pain, and you can check off these things, it makes it easier for the providers. And then, of course, we've done a lot of education with the providers. We've done education with the doctors on the floors in the ER. Most recently, now we're working on pain protocol or pain order set, where basically what a lot of hospitals have done for insulin, where there's long acting insulin, short acting insulin, how to check sugars more frequently so that you run into less problems with hypo and hyperglycemia, is now we have a whole pain order set that is smart, and it uses, like, if someone has kidney function issues or liver function issues, certain medications will automatically not pop up, so that patients won't accidentally get like an ibuprofen if they have kidney issues. This will be the only way to order opioids. They can't just give someone oxycodone. They want to give them oxycodone, they have to go to the order set, and the order set has your non-opioids there, your opioids there, so you're always actively thinking about other options to give than just automatically going to opioids.
Absolutely. Thank you for that. I may come back to you here with a question, but I want to give Lauren the
Yeah.
opportunity to jump in a little bit as well.
I think we always say this in our department, but we will never have enough providers to provide the treatment needed for the need of our community. So we really have focused a lot on prevention. So a lot of what Dr. Dave is saying in terms of limiting opioid initiations and leveraging our electronic medical record to provide better care. He's gone out and done lots of trainings. We've done some targeted trainings to certain providers who need that further education, but we've also done training for our patients when they are prescribed opioids. So, anytime a patient is prescribed opioids at discharge, they're automatically provided educational materials to better understand what they're being prescribed and how to not, misuse the prescription.
I should share with you, we worked with the CDC, AHA worked with the CDC probably about 5 years ago now, but I think it is still very on point and helpful. We have a two-pager that we can provide to families and patients. So not just the patients, but letting the family know what are some of the signs and symptoms, if they start to see, perhaps abuse of, the opioids if they do go home with them. So my next question is, I think you've also developed a screening tool for OUD, probably much broader, but for all substance use disorders, particularly given the statistics that you just said, Dr. Davy, regarding what happens upon admission and discharge. So, can you tell me a little bit about the screening tool and how you baked it into your EHR?
So we've implemented the opioid risk tool, which is probably the most studied one out of what we have right now. And it's implemented into our EHR, where anybody can put the phrase in .ort or .risk, and it pops up. And it's also part of our preoperative screening as well. So in the preoperative area, if someone is tagged to be a high risk, then they're referred to a pain management provider so that we can follow them post-operatively if there's any concerns. We've done education with the residents and the hospitalists about using this tool. So if they do start someone on opioids in the hospital, they're able to understand what risk factors the patients have. And then we've shared this with our outpatient providers as well, because we have hundreds of primary care doctors that are part of our network. So they can use that as well when they're prescribing opiates to their patients.
Lauren, what would you like to add?
Yeah, so in addition to the opioid risk tool, we've also implemented a screening tool in our emergency room. So I'm going to go back to my point of prevention, that if we can screen individuals and earlier determine whether or not they have a substance use concern, we can provide them the correct resources and connect them to the appropriate level of care. So all individuals who come to our emergency room, I believe it's 18 and up, we are screening for all substances, opioids included, and any patient who screens positive will receive counseling by one of our emergency room doctors by our social workers. And if needed, a social worker will make a referral for that patient for additional services.
I have to admit, one of my biases is that that's the wave of the future, to screen for psychiatric and substance use disorders for every admission. It's somewhere between 1 in 4 or 1 in 5 admissions to the hospital has, and it's probably much higher than that in the emergency room, has a comorbid psychiatric or substance use disorder. That is not, as you said, their presenting diagnosis or the presenting reason for their admission, but it's there nonetheless. And we should always take the opportunity to identify and treat if needed. And also, that happens sometimes to improve outcomes and shorten length of stay. And anyway, I could speak on that for hours. I won't here.
You are correct, though. It's about 20% of the individuals we are screening have a positive screen for substance use.
As we begin to bring this to a close, let me ask you this key important fact. What's the impact been for all this work, for creating the center, for implementing the screening programs, for doing the training, for changing the culture, quite honestly, for using technology to help in decision-making process? What's the impact you've seen?
One impact I can share, I think you touched it when you just said changing the culture. Englewood Health has really recognized that 20% of the patients that we've screened in the emergency room are in need of additional counseling and support. So just 2 months ago, we have now opened an outpatient addiction medicine office so that we are more easily able to treat the patients that we identify within our own system.
And I can follow what Lauren said. I think, we've seen a huge difference just from the hospital side, from our providers, from our residents when, they're ordering. I'm seeing less opioids being ordered if we're ordering opioids. Even the nurses are sometimes questioning it, or they'll ask me on the side, like, is this appropriate? So there's this huge culture shift that we've seen with the education. And I think making the providers feel comfortable using other medications and not feeling like they have to go to an opioid first, that it's kind of domino affected throughout the program. And we're seeing outpatient providers, inpatient providers really trying to make sure that they're only using the opioid when they feel it's really appropriate and it's not the first thing that they're going to in terms of treatment.
That's phenomenal. What would you say are 2 key success factors that allowed you to do this? Was it, a champion like Dr. Davy stepping up and saying, "We've gotta do this, and I'm here to be a team player to make it happen"? Obviously, I think earlier you mentioned, a wonderful philanthropist that allowed you to have the funds to do that. But what are a couple of key success factors that the listeners would need to know about to implement something similar in their own organization?
I think for our stewardship, it really was a collaboration of different disciplines coming together, and recognizing the role that each of us plays in this process. Because it was all of us working together that we were able to implement all of these workflow changes and utilizing our electronic medical record and the education of our providers and the education of our community. It required all of us to work together to achieve the goals we set forth.
I was thinking the same thing that Lauren said. I think it's really getting the providers in different areas to really bring this together and make it move forward quickly, whether it's, someone from IT, whether it's, someone from social work, whether it's the ER doctor, the chief of anesthesia, chief of medicine, chief of psychiatry, and then, Lauren making sure these meetings happen on top of it, and we're making sure we're planning for it beforehand, and then making sure we have a plan for the next one. And really, I think a point person, and then being able to get the right people together to implement it, and then everyone being passionate about it. Everyone on the team was excited about, we want to try to do this. We want to try to reduce opioids, and we want to try to, get better care for our patients.
Awesome. Well, thank you so very much for your willingness to share your time and your expertise. I'm hoping that this podcast, along with other work that AHA has done and that you have done, will inspire others to go on this journey for this very, very important clinical disease and disorder. And I again say congratulations on being one of AHA's Foster McGraw Prize finalists. And I will point the listeners to AHA's resources on opioids at aha.org/opioids.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.